Hi guys, good evening and welcome again. We are here to do the obstetrics questions, and that is we are having the ideas to give you as many clinical situations as possible. And we did gynae yesterday, and obstetrics has many questions coming in your exams regularly. The tough questions coming from puerperal fever and antepartum hemorrhage, and of course also from postpartum hemorrhage. There is something about PIH always in the exams, and so is about GDM. So apart from this, don't forget that you must never leave your homes without reading fetal surveillance. Now, fetal surveillance is what makes you an obstetrician. If you know the drug of choice for hypertension is levodopa, and you know the drug of choice for diabetes is insulin in pregnancy, that's going to be the pharmacological part only. But if you know how you continue the pregnancy from diagnosing, let's say, hypertension pregnancy at 28 weeks, now you have to continue this pregnancy with mild BP, high BP or severe BP, and continue the pregnancy till 37 weeks at least. And in that few weeks, the baby should be fine. He should not have IUGR. He should be growing well. His parameters should be adequate, and the mother should not have any complications. So how you make sure that everything goes fine? That's what is because of fetal surveillance. So apart from the topics which I said, the one which I'm talking about now, the fetal surveillance, don't leave your homes without reading fetal surveillance, and that goes very strongly for the PG entrance exam. Even more detailed discussion on fetal surveillance will come, and of course the MCI students, you must understand that you should at least know all the various tests which are coming, and you must know about biophysical profile and NST very well, including cardiotocography. So with that introduction, let's get into the questions which we have for you today. So the first question, we have made a lot of wordy questions so that you people get into the thing about next, about the clinical situations which are going to come in your life. So there's this 29-year-old lady who delivered 7 days back. She presents with complaints of lower abdominal pain since 3 days and of some fever. Her delivery was uneventful and she's breastfeeding the child. On examination, there is temperature of 101 degree Fahrenheit, pulse rate is 110, blood pressure is normal, respiratory is 14 per minute, bilateral breaths are mildly engorged. Abdominal examination shows abdominal tenderness, but there is no rebound tenderness. Per vaginal examination, there is foul smelling blood mixed discharge with uterine and fornical tenderness. CBC is 10.8 grams per deciliter, and the total leukocyte count is 20,000. Look, in you and me, we have around 4,000 to 7,000 count of leukocytes, but in pregnancy it can be normal up till 12,000. And a lot of our patients chronically throughout pregnancy stay between 10,000 to 15,000 TLC. But yes, even with 15,000, they don't have a problem. But if it is anything more than that, then we are thinking about sepsis. So this is 20,000 and she just delivered and she's having fever. So this is not to be ignored. Now, ultrasound reveals heterogeneous content in endometrial cavity measuring 3.2 into 2 centimeters. Now, that's the crux of the whole question. 3.2 into 2 centimeters mass with free fluid in the pouch of Douglas. Which of the following is the most appropriate next line of management? So, look, most of you are already answering the correct answer. Yes, we will obviously think in terms of postpartum endometritis, and there's nothing wrong with the breast. There's no incision on drainage of the breast required, and IV clindamycin plus IV gentamicin. Now that is the gold standard. That is the the best method by which we always, sometimes we don't even do the cultures. We go ahead and give clindamycin and gentamicin as the best method, gold standard of treating postpartum endometritis. So laparotomy is not required just as yet because the patient is not in florid peritonitis and there's no evidence of once we don't get a response, then only I think in terms of laparotomy. Episiotomy exploration, yes, they've not mentioned anything about the episiotomy, but yes, there are patients who've got bad florid infected episiotomies which have caused a good systemic infection, and that kind of systemic infections, yes, only a bad suppurated episiotomy can cause. So, but yes, that information is not there in this question. So, we'll go ahead and mark IV clindamycin, gentamicin as the best option here. So, all of you got that correct. Now, I was just trying to show you a slide of puerperal fever. This is there in a rapid revision as well. So, fever in the first 10 days is generally this puerperal fever, and please don't include the first 24 hours. Look, if a woman has just delivered, she's delivered at 6 p.m. then till tomorrow evening 6 p.m. if the fever is high, that's not a puerperal cause of fever. That is not because of a puerperal post-delivery cause. Suppose she's delivered at 6 p.m. and at 10 p.m. her fever is 101, 102. That is probably because of any event which was during the labor, or before that there was some viral infection or something like that. It's not because of the delivery, and there are some complications beyond delivery like mastitis or endometritis, puerperal sepsis. All of that is not the cause if it is within the first 24 hours. So after the first 24 hours, if there is fever, then we think in terms of puerperal causes. So yes, the common causes are the endometritis. Most common is endometritis. Group A beta hemolytic streptococci is the most common agent. Okay. And clindamycin and gentamicin, that's the gold standard treatment. But remember, prolonged labor, PROM, and too many pelvic examinations are the causes of this. Yes, we should all remember when a patient is in active stage of labor, which is 4 centimeters still. So from 4 centimeters onwards, when a woman is in active labor, we want to examine her every once in 2 hours. So how much do we expect the dilatation to be in every 1 hour? At least 1 centimeters. How much do you expect the descent to be? At least 1 centimeters. So yes, in 4 centimeters to 10 centimeters is 6 centimeters dilatation. So that should happen in 6 hours. So active stage of labor, this duration is asked so many times. So for this 6 centimeters, you need 6 hours of labor. So mostly we say, what is the duration of labor in a multigravida active stage of labor? 4 to 6 hours. How much can it be in a in a primigravida? Primigravida, it can be 6 hours to sometimes 8 hours. So yes, if you remember this 6, then you are very clear about the durations which are asked in the exam. So 4 centimeters to 10 centimeters is the dilatation which is to be done in active stage, should require 6 hours or lesser. Fine. Breast encouragement also can cause puerperal fever, but then let's go to the next question. So if the count is less than 10,000, if the count is less than 10,000, then there is no systemic response to the infection. There is some endometrial collection and there is some mass which requires, curettage. Yes, we know that, but the patient does not have a high TLC. All right, if the TLC is not high, that means the systemic response has not yet happened. Maybe she's not yet got a systemic infection. Maybe her immunity is not so good. Those reasons also you have to see. But you may see some patients having fever without a very high TLC also. Okay, that doesn't mean if the TLC is not high, I will not give antibiotics when she has fever. She has fever, she has collection inside the uterus. I'll go ahead. Anything in the uterus if you do, especially if it is puerperal, please don't say I will not give antibiotics. Sir, I'm doing in a sterile environment. I'm making sure I've cleaned the vagina and the vulva, perineum, everything with betadine, and I've given good Savlon wash, and I'm going to do in a clean method. Please, the uterus can never be clean in a puerperal state because it has blood and some lochia which is coming out, the scar of the placental site of implantation. That side is still oozing a little bit in the puerperium, especially in the lochia days. So whatever procedures you do inside the uterus, please do under antibiotic cover, especially puerperal. All right, be very careful. And we always give broad spectrum antibiotics like the one which I showed you here. Okay, so question number 2, what is Dr. Vishal Mishra, how is this exam going to be like August 2020? So that's an MCI student, I'm sure, because August 2020 is something which is still in the minds of all students. Please remember, August 2020 was a mild exam. So compared to what is going to happen now. So please be ready for the tough exams. You guys are going to be ready because you got this extra 45 days. You've been reading. Still there's some 15 days left. So don't worry about the questions which are going to come. If they're tough for everybody, not just for you. So you've been reading, you've read all the 19 subjects from your 19 favorite doctors, and all their favorite doctors who are the 19 of them, they are having a presence on YouTube. You're getting free questions from PrepLadder, right? All the teachers who are taking care of you, all the teachers who are taking your classes, they have a YouTube presence. At least 5 years, all the question papers have been solved. So why do you have to see anything else? You don't have to go looking at notes of this institute and that app and that friend of mine who's made very good notes. Don't get yourself into more confusion. Your favorite teacher, whoever is your favorite teacher, pick up one teacher for surgery, pick up one teacher for gynae, medicine, whoever is your favorite teacher, and follow that teacher. That's a very, very simple advice. And that teacher is, see, every teacher will have some mistakes, but 95% of all of us, I speak for all the doctors who are taking classes, any institute, 95% of all of us are correct. Maybe some of us are 90 to 95, but not worse than that. So if we are getting 90% correct information for you, and you remember that information, and you do the questions from these teachers, how can you get less than 90% in your exams? We are covering all the topics, and at least 500 MCQs from me alone you will get on YouTube for free, because for the last 5 years all the exams we've solved the questions for you. We've given you one-liners, we are doing these sessions. So if you're following one teacher, then the confusions are lesser, right? Maybe I might be a little different, the other teachers might be a little different from me. Maybe one or two questions you may get wrong because the confusion between the teachers and the facts between the teachers. But that won't spoil your total marks. If you're getting, let's say there are 40 marks for gynecology in NEET or in MCI, and you're getting 36, 37 marks, I think you're going to get a good rank, right? So keep following that. Okay. Yeah, thanks, Dr. Dwivedi, and let's move on. 29-year-old primary graduate presents to the emergency room with pregnancy of 7 weeks duration. She has excessive vomiting and vaginal bleeding. On examination, pulse rate is 120 per minute and blood pressure is 150 by 100. Dipstick urine albumin is 2 plus. Uterine size corresponds to 16 weeks. Vaginal examination shows mild blood mixed vaginal discharge. Which of the following is the most likely working diagnosis? So yes, she is 7 weeks pregnant and the uterus is 16 weeks size. So can that be twins? Let's see. She has excessive vomiting, can happen in twins, and there is some vaginal bleeding, can happen in twins with vaginal bleeding, can be threatened abortion. Pulse rate is 120 per minute and blood pressure is 150 by 100. Now, if the blood pressure is 150 by 100, now we call it a early onset hypertension. So now I start thinking apart from twins. Okay, now twins also, the uterus won't be so big, it won't be double the size. So there's only one thing which comes in early obstetrics where the uterus is much bigger than the period of gestation. Yes, all of you are obviously getting it correct. Yes, it is a molar pregnancy. See what took the diagnosis away? That such early pregnancy, you will not have albuminuria, you will not have hypertension even if it is twins. So that's why it is early onset hypertension, uterine size more than the period of gestation. These are things which tell you that it could be a case of molar pregnancy. Okay, so that's molar pregnancy. Remember, if at the diagnosis, remember, if at diagnosis of molar pregnancy, the theca lutein cyst is more than 6 centimeters in size and the HCG is more than 10 to the power 5 milli international units and uterine size is large. If these are present at the diagnosis of molar pregnancy, then there is a increased chance of choriocarcinoma later. All right, very interesting topic, my favorite topic. I love this topic because where I've done my MBBS and MD from, in the south, we used to get so many cases of molar pregnancy. That's also telling us that yes, Southeast Asia, the rice eating population has more molar pregnancy than the other population in the world. And yes, in Japan, we used to see many cases of molar pregnancy. We've done a lot of evacuations. In fact, I was lucky to have done an evacuation even when I was an intern. But yes, that was under a lot of supervision because that can get a very difficult evacuation. But yes, we did a lot. Internship is a wonderful time of your life. Those who were trying to evade internship, now you know that your second part of the exam will be after your internship. So yes, my friends who are in the final year right now, and maybe the 2019 students may just escape. That's what is getting to be the information. But yes, don't take my word for it. I'm nobody from inside. I'm just trying to say that maybe the 2019 students may escape, and 2020 onwards you will get that exam, and you will have to make sure that you're doing your internship very earnestly, and whatever things you learn in your internship are going to make you a very good clinician. Suppose even if you do, you do a good paraclinical subject, I mean you do a preclinical subject, you do biochemistry, but your basic skills should be good. That somebody falls sick in your house, you should be able to start a line, you should be able to give the basic initial medication. If there is a problem in the house, you should be able to give the basic initial management because you're a doctor, you've done your MBBS and you've done your internship. So keep that in mind, that what you learn in internship may save a life in your house one day. Okay, next question. what are you guys asking me here? Okay, hi. Okay, Hindi में बोलिए, right? Aditya Sharma, मैं तो हिंदी में बोल सकता हूँ, but नरिया पेर तमिल पेसवांगा के तमिल तेवे पढ़ूँ, इन्ना पढ़ूँ, then we can't help it. So Hindi, Punjabi, we can't help it. We'll have to stick with English, right? The language which not all of us like, but then that's how we have been brought up. Yes, we respect our Indian languages, we respect our mother tongue, but the mode of instructions is still in English. The exams, international exam, Indian exams and international communication, your presentations everywhere is in one standard language. Unfortunately, that is English. So we must know the language. So ठीक है, मुझे अच्छा लगता है हिंदी में बोलना और पंजाबी में और भी मजे आते हैं, तमिल में तो सबसे ज़्यादा मजे आते हैं. But yes, we have to speak what we have a international code, right? A 35-year-old second grader presents in third month of pregnancy with vaginal bleeding and excessive nausea and vomiting. On ultrasound, there is a greatly enlarged placenta with multiple cystic spaces alongside a gestation sac with an amorphous fetus. Suction and evacuation was done and histology confirmed focal trophoblastic hyperplasia and hydropic swelling of coronary villi. Which of the following is the most likely genetic mechanism of such a presentation? Well, this is again something to do with the molar pregnancy. She's a second gravida in the third month of pregnancy with vaginal bleeding. And ultrasound, there's a multiple cystic spaces alongside a gestation sac with an amorphous fetus. Now that means the fetus anatomy is not looking very good and there is a placenta which is looking like it is degenerated. Most of the times a partial mole can give this kind of a picture. So yes, what happens in a partial mole? We say that in a partial mole, the oocyte, the genetic material which is dispersed, the oocyte gets one sperm inside for fertilization normally, and that is going to make the genetic material of the female to condense and make a 23X, and the genetic material of the male to condense and make too big, a 23X from the male. So that is from the female, this from the male, and this is going to make a 46XX chromosome. Now this is how normal sexual fertilization takes place, and if this oocyte gets fertilized by not one but by more than one sperms. So yes, if one sperm and another sperm gets in like this, so that is now going to make a 23X from the female and 23X from the male, another 23X from the male. So that's going to make 3 sets of chromosome inside this zygote. So this is going to be a 69 triple X. Now that is not a normal set of chromosomes. It is not a diploid zygote. It's a triploid. Please, it is different from trisomy. It's a triploidy. So this is a triploid chromosome, and this is the most common. This is the most common chromosome in cases of a partial, most common zygote, most common type of karyotype of a partial mole. So that's what happens in a partial mole. One oocyte gets fertilized by 2 sperms. So that is going to make a fetus. On the ultrasound, you will see a fetus, and it's going to make a placenta. Placenta will have normal architecture, but will have some villi which are cystic. So partial degeneration of the placenta. So this is a non-viable fetus. So this baby is not going to make beyond 12 weeks to 16 weeks. It is a non-viable fetus. It's going to abort by itself. So that's what we say is a partial mole. So what is this? This is a partial mole. Suction evacuation was done and histology confirmed focal trophoblastic hyperplasia. As compared to a complete mole, there is diffuse trophoblastic hyperplasia. And there is, the following is the most likely genetic mechanism. So euploid fetus, no, this is not euploid, it is triploid. So that's wrong. Diploid fetus with haploid sperm endoduplication. I'll come to endoduplication just now. We are just talking about the partial mole, so that's also not the correct one. Triploid fetus with dispermic fertilization. Now, how many of you got that correct? Partial mole. Yes, C. Many of you got it correct. Dr. Nissi, Dr. Arnab, yes. Danish, Danish has got D. No, Danish, D is wrong. So, triploid fetus with dispermic fertilization. It's not a diploid fetus. See, itself, you know, there's so much of jargon here and you people might tend to get confused, but there's only one choice which is called triploid. So triploid fetus with dispermic fertilization means it is just trying to say that the fetus has a 3 set of chromosomes and there are 2 sperms which are fertilized to make this. So if you remember the basic, how it is formed, then all this jargon which is there in the questions which not confuse you at all. So yes, the answer to this is C. Okay. So now what happens in a complete mole? Let's see, I'll try to show you what happens in a complete mole. In a complete mole, you will see that there is a empty oocyte. An empty oocyte that gets fertilized by a sperm. I'm sorry, excuse me again. Empty oocytes get fertilized by a sperm. So that's going to make a 23 eggs from the male and nothing from the female. Now this is going to undergo, since it's an empty oocyte, but it's not a dead oocyte, it's got some electrical charge and it undergoes a endoduplication. So endoduplication which happens, this is going to make the embryo have a 46 XX chromosome. But see here, there is no maternal contribution, there is nothing from the female, only paternal chromosome has duplicated. So these both X chromosomes are paternal. So this is what is coming in your exams very regularly. What is the origin of these X chromosomes? Both are paternal, and this is going to cause diffuse degeneration. All the villi which are going to be formed are going to be degenerate. So that's why that typical look which you know on your ultrasound, that all the villi are going to degenerate and become vesicles. So that's why you're going to see a vesicular mole or a complete mole. So in a complete mole, in a vesicular mole, you see this snowstorm appearance. The snowstorm appearance. Now if I'm telling you snowstorm appearance, this is that one MCQ which all of you know very well the answer on the ultrasound when they show you a picture in the image based question, snowstorm appearance. But somehow it is so easy, but it's been coming in your INI-CET exams, it's coming in your MCA exams very regularly. Alright. So INI-CET students, some very easy questions come, and it's for you to go and grab those marks, so that 1 or 2 tough questions also do come in INI-CET, but these easy questions you must always get them correct so that your rank is assured, and then those 1 or 2 questions make sure that you get a higher rank. So let's move on and see the differences between complete mole and the partial mole. Complete mole is diploid, partial mole is triploid. And what is the fertilization? In a complete mole, there is a 46 XX with a haploid sperm endoduplication, which I just now showed you. And a triploid, I just showed you that there will be two sperms in oocyte, so that will be a triploidy. But yes, there's another method. There's another method of, now that we're discussing mole in so much details, let us finish this. In a complete mole, you may also see in a complete mole that the empty oocyte, rather than undergoing a endoduplication, there is another method, that there are 2 sperms which enter carrying 23X and 23X. So that's going to make a 46XX. So that's another method of a partial mole. Another method of a complete mole. I'm talking about complete mole. And there's yet another method that 2 sperms will enter the oocyte. One will be 23X, one might be 23Y. So that's going to make a 46XY karyotype for a complete mole. But complete mole, there are three methods by which it can form, but most common is an empty oocyte getting fertilized by a 23X carrying sperm, and that's going to undergo endoduplication. Alright, so we are trying to tell you this, that the other method of complete mole is 46XX with a dispermic fertilization, which I just now showed. All chromosomes are paternal, yes, androgenesis, and partial mole, extra set of chromosomes is present, which is paternal. No embryonic fetal tissues here. Fetal tissues are seen here. In partial mole, diffuse hydropic swelling, and this is focal hydropic swelling. So there is diffuse trophoblastic hyperplasia in a case of a complete mole and focal trophoblastic hyperplasia. But yes, what is finally clinching the diagnosis? This came as a NEET exam question, that all of this which I have told you in the full chart, this may be present or might not be present. On the ultrasound, you may see some features like in this question, that in a partial mole, you'll see a fetus with a partly degenerate placenta. You may see these features on a histopathology, focal degeneration of the trophoblast, but sometimes everything looks the same on histopathology also. So finally, what is that one thing which will give us the ultimate distinction between a partial and a complete mole? That is the P57 immunohistochemistry. So in that, P57 staining is negative in a case of a complete mole, but it is positive in a case of a partial mole. Why? Because P57 is from a maternal gene. Okay, it's a maternal contribution. So in a complete mole, both the X chromosomes are paternal. In a partial mole, there is a maternal contribution also. The maternal chromosome is intact. That's why P57 is seen in partial mole. All right, let me see what you guys are answering here. Good evening. Last 15 days from watching this part revision. Okay, fine. Very good. Snowstorm appearance and conjoined twins. Let's see. There is a question on twin somewhere. Conjoined twin. Okay, you've been asking me about this. All right. Okay, guys, let's move on. A pregnant woman in her first trimester of pregnancy attends the antenatal clinic for routine investigations. On routine screening, her urine shows 35 WBCs per high power field and a culture test positive for E. coli. And the count is more than 1 lakh colony forming units. And that is pan sensitive, means almost all the drugs which I am trying to do the culture sensitivity in the panel of drugs which we use against some bacteria has come positive. That bacteria put in a dish with all the antibiotics and we see if these antibiotics are inhibiting the growth. So in the culture we see that it is pan sensitive, means all the antibiotics which I am using against this E. coli, it is showing good, those antibiotics are showing good action against this E. coli. She does not seem to have any urinary symptoms, but she has got E. coli growing more than 10 to the power 5 colony forming units. So what is the most appropriate next step in this management? Now this is exactly what we call asymptomatic bacteriuria. So asymptomatic bacteriuria is a condition where women may be harboring this bacteria without having any symptoms, but even if she is asymptomatic and you catch it, please don't ignore it. All right. This is very important because we will screen all pregnant mothers for doing a urine routine examination. Once in a month we do it. If there is nothing wrong, we do it on a monthly basis. Some places they do it once in 3 weeks. And if there is a positive leukocyte esterase test or a nitrite on dipstick, if that is positive, then there is some infection, then we do a culture. Now, complications of asymptomatic bacteriuria is development of symptomatic infections, pyelonephritis, low birth weight, IUGR, that is might be present, preterm delivery, preeclampsia and even anemia. So that's why asymptomatic bacteriuria, even if it is present, I'll go ahead and give nitrofurantoin for 7 to 10 days. So that's what we do here. No treatment till she develops symptoms. Wrong. Urinary alkalizer with plenty of fluid intake. No. Repeat urinary microscopic and culture, not at all. We've already got something positive. Go ahead and give nitrofurantoin as the management. How many of you got that correct? B for Bombay. No. D for Delhi is the answer here. Okay, so those who got it correct is fine. No treatment, no, my friend, you'll have to treat this. Asymptomatic bacteria you must treat because they are complications. So that's why what do we do in antenatal care? There's a very good, okay, fine, you can see my video rather than the book. You can see there's a video of antenatal care free of charge on YouTube. Go ahead and see. Don't subscribe to my channel. I don't know who is running my channel, so just don't worry about the channel. Just go ahead and put my name and you'll see antenatal care and you'll see a free lecture on what you should do, how you take care of a woman who's coming to the OPD and what are the tests you do. So one of the tests which we do apart from a urine routine, CBC every month, we do a urine routine examination. That's to pick up these kind of infections and treat them when they are lurking around without any symptoms. All right. Why not E, tablet levoflox? See, nitrofurantoin is a much better, action on these infections, and that's why we say why not ampicillin then? Earlier they used to give that. So nitrofurantoin is a much better charge on, much better treatment for these. So we'll have to go with that. Levofloxacin we don't give in pregnancy in the first place. Quinolones are contraindicated in pregnancy. So you'll have to think in terms of drugs which are safe and which are effective. So not levofloxacin, definitely not. Let's move on. So depicted instrument is used in which procedure? See that numbering of the question is a little wrong. So this is question number 5. Okay, it's a depicted instrument shown in what is this procedure? So this is an old-fashioned instrument which is having these two prongs. Can you see these two prongs? If you see here, there are two prongs like this. These two prongs are, these two prongs come out of this instrument, and with that we go and hold the fallopian tube and pull the tube into this cylinder of this instrument and slip a ring over it. All right, so this ring here is, okay, I'll show you in yellow color here. This ring is already charged here on this instrument, and that when you pull the tube inside, we pull the tube inside and slip the ring over the tube. So this is what is used for a tubectomy, a laparoscopic tubectomy. Yes, this is known as the laparoscopic ring applicator. In short, the laprocator. All right, guys, and this is not for a punch biopsy. You guys know what is a punch biopsy forceps, so I'm not showing you that. It is for a tubectomy and bone marrow biopsy instead. Okay, Jamshidi needle, that's not here. And trocar and cannula for laparoscopy. Now, I can show you that from my set of instrument. This is how trocar and cannula is used. So this is the trocar. Okay, this is the trocar. Trocar is a knife, it's knife, trocar, knife. The stabbing device, the trocar, and the trocar goes into the cannula. Then both of these together we use to insert into the abdomen, and then we take out the trocar. Through the cannula we put a laparoscope. Okay, question number 6. A 36-year-old gravid para 1 with twin pregnancy presents to the labor room at 37 weeks of gestation with labor pain since last 4 hours. So she's at term and she's in labor for 4 hours. Her last obstetric scan is suggestive of twins. All right, somebody wanted to know about twins. With first breech and second cephalic with an amniotic fluid index of 11, which is normal. 11, 10 to 15 is normal AFI. All right, so this is normal. On examination, the blood pressure is all right, 140/80, pulse rate is 100 because she's in labor. Fetal heart rate tracings are reactive and uterus shows 2 contractions in 10 minutes. So she's having mild contractions, getting into active labor types. Service is, because in active labor you must get at least 3 good contractions in 10 minutes. So that is, cervix is 3 centimeters and LICA is clear. That means she has ruptured a bag of membranes also. Which of the following is a likely indication to proceed with a cesarean section? Yes, if I have to do a cesarean in twins, in this history which we are seeing, what is that reason? So, all of you are getting it correct? Yes? Oh no, some of you, that was the previous question thing, I think. Yes, all of you got it correct. So, is an elderly gravida a reason of a cesarean section? Look, in private practice, everything is a reason for cesarean section. The reason for cesarean section is that she's pregnant. That's what is happening in private practice these days. So, guys, they'll find some reason to say, the biggest scam which is running in the private market, and I'm a little scared of saying that online, but that is that there will be a report of an ultrasound which is showing that there's a cord around the neck, and that cord around the neck is going to cause the baby to get strangulated during labor, and baby is going to die during labor. So I'm telling you what is going to happen to your baby. So if you want a normal delivery, go ahead and get it done, but I would advise a cesarean. So that's how it is being told. Cord around the neck is no indication for a cesarean section. Please, guys, those who are here, those who are interns and they're answering that cord around the neck is indication for cesarean, that's absolutely hogwash. Please, cord around the neck, day in and day out we are showing deliveries, and we are doing, even as recent as yesterday, I was doing laparoscopy in my OT, and there was a patient who was brought for a trial of forceps in the OT. If it fails, they'll do a cesarean. So my PG was delivering that baby, and in the OT, the next OT where I was doing a laparoscopy, the next to that, somebody was doing a delivery in the operation theatre because the forceps worked. Moment the baby came out, there were 3 loops of cord around the neck, and the baby was perfectly fine. Nothing was wrong. The baby is next to the mother. You can go and check St. Stephen Hospital yesterday. Okay, so I'm telling you, cord around the neck is no indication of doing a cesarean section. So cesarean section is done for so many reasons in the private practice, but yes, please remember, elderly gravida is not an indication. Now we are talking about this patient. In this patient, what is the indication of a cesarean section, if at all? So twins with elderly gravida is not indication. Twin pregnancy is not an indication for cesarean. The first twin is non-cephalic. Now that could be a reason. So yes. Otherwise, inadequate uterine contraction, no, she's just gone into labor. Wait for the contractions to become good. If they're not becoming good, I'll increase more oxytocin, I'll make a partogram, and then I'll say it is inadequate uterine contraction or whatever. Inadequate cervical dilatation with absent membranes, not at all. If there are absent membranes, I'll increase the contractions and I will make sure she'll deliver. So that's what is obstetrics all about. So none of these could be the answers. Okay, they don't find favor with me. So first twin is non-cephalic. Maybe that is the best answer here. So yes, in twins, both are cephalic. That is the most common presentation. Both twins are cephalic. Now, the second most common was asked in the NEET exam. It is first cephalic and the second one is breech. All right. And the third one is that the first could be a breech. So when the first one is breech, look, we always say that breech should deliver normally. Okay, don't say breech is an indication for cesarean section, but if there is breech with twins, now that becomes a complicated breech. Complicated breech is something you'll have to do a cesarean section. So if there's a breech with a previous cesarean, so that itself becomes an indication. If you say breech by itself, not indication for cesarean. If you see previous LACS, I'll give trial of labor. But breech with previous cesarean becomes a complicated breech. So whenever we ask you this term, there's a woman with complicated breech. So whatever is the story behind that, just go ahead and do a cesarean section. Breech with an IUGR baby, go ahead and do a cesarean. So wherever there is a complicated breech, we think in terms of a cesarean. So yes, this is twins with the first breech. I would do a safe cesarean in these. So yes, most of us take pride in doing good obstetrics and doing normal deliveries and pushing for normal deliveries, but don't be foolhardy. You should not do normal delivery at any cost. No, that is not correct. Try to do normal deliveries, get a good earnest effort to do a normal delivery. If it is not happening, then you should do a pretty good cesarean also. So if you're doing a cesarean section in tertiary care setup, your cesarean rate should be between 15 to 20%. Yes, this was a PSM question in NEET exam long back. What is a good cesarean rate in a tertiary care hospital? 15 to 20%. My hospital where I'm working and when I was in my PG, the cesarean rate was 30-35%, and there was always that my HODs were always making sure that in the meetings, in the monthly audits, they were always screaming at us. They said, how can you touch it even beyond 25%? So 30% was a nuisance. These days we have hospitals which are having 90% cesarean rates. So, this is going really out of control, the number of cesareans, because of litigation. Anything going wrong after a normal delivery, there is so much of litigation that obstetricians are playing it safe. But yes, that's where good obstetrics come into practice. If you are sitting with the patient and making her deliver, what is the meaning of obstetrics? Standing before a parturient. That's what is the meaning of obstetrics, standing before a parturient. So if you're standing with the lady, you're monitoring her throughout her labor, and if there is something wrong, then you will do a cesarean. If you know what is right and wrong, then that is your training. And if it is going smooth, then you will be able to do a normal delivery. For that, you have to sit with the patient who is delivering, and nobody has a time to do that. That's why most cesareans, all right? कौन सर दर्द लेगा, விடுங்கப்பா விட்டுருங்க, cesarean பண்ணலாம், straight cesarean பண்ணலாம். Okay, that's what people are saying. Okay, let's move on and see what is the conjoined twin. Somebody was asking me. Now, conjoined twin is when the embryo splits after 12 days. So there the plate, embryonic plate, is already formed. When the embryonic plate is already formed, the problem is formed, all right? So when the embryonic plate is already formed, then if the cell mass is split, then there will be sharing of some organs. So that's why after 12 days, if the embryo splits, there will be sharing of organs, like the chest might be stuck to each other in the twin. So that is a thoracophagous. That is the most common type of conjoined twin. So thoracophagous. Now that MCQ has come many times in NEET, but remember, what are the twins which will survive the most? So most common is thoracophagous, but the craniophagous has survived the most. I mean, I will not be able to say that. I mean, I'm so sorry. Let me just reframe my answer. Craniopagus is what you see in the media most commonly, because these are the ones who will survive. The surgery might be not as good as the results might not be as good as you expect, because sometimes the parapagus might do better. Okay, so in media, what you see very commonly, I am correcting my statement. In the media, what you see on television, on the newsprint, you see the craniopagus. Yes, Dr. Ben Carson, the story of Gifted Hands, if you've seen that movie, that's about craniopagus twins. Yes, there's one Dr. Ben Carson who was there yesterday watching the gynae questions. I hope, Ben Carson, are you here? Good evening. You are again mentioned in the discussions here. So craniopagus was the one in which this surgery was done for the first time successfully. So surgery results might not be very good with craniopagus, but that's the most common you see in the media. Otherwise, most common is thoracophagus. Now, a 26-year-old lady presents to the physician with history of missed periods and a positive urinary pregnancy test. Okay. Now, she now complains of spotting of vagina and mild pain lower abdomen since 2 days. There is no history of passage of any products. Her beta HCG is 5,433 milli-international units. Which of the following is the next best step in management of this patient? She is pregnant, her HCG is 5,400 and she's got some spotting and bleeding. Any woman who bleeds in pregnancy, you say she is aborting, isn't it? She may be aborting, or she could be threatening to abort, or she could be into an incomplete abortion already. There can be so many things when a woman is bleeding per vaginum in pregnancy. So early pregnancy, woman bleeding, alarm. She could be aborting. Examine her, do a per vaginal examination, see the findings of the cervix, and then do an ultrasound and see if the baby is dead or alive. So when a woman is bleeding in pregnancy, think in terms of abortions first. If the uterus is normal size and she's pregnant, let's say 7-8 weeks, think of ectopic pregnancy, because that will also present with vaginal bleeding. So yes, which of the following the next best step? Repeat beta HCG after 48 hours. No. Look. This patient is pregnant and the HCG is high enough for you to catch where the pregnancy is. That is what is known as the discriminatory zone. Discriminatory zone of HCG is 1500 international units for transvaginal sonography and 6500 for transabdominal sonography. So if you see a HCG of 5000, you should be able to see the sac whether in the uterus or in the tube by your transvaginal sonography itself. So now you don't have to do doubling. Look, doubling of HCG, it doubles in 48 hours in a normal pregnancy, it doubles in 5 to 7 days in an ectopic pregnancy. All that information is used when you cannot see the sac on ultrasound. So if you have a level of more than 1500, 5000, you will be able to see a sac either in the uterus or in the fallopian tube or somewhere else in the pelvis. So you need a good gynecologist or a good radiologist who is doing the scan, and you will be able to pick it up. So 5400, we will not say do a repeat value because it is more than the discriminatory zone. So that's wrong. DNC, not at all. You don't know where the pregnancy is. Why will you go and do a DNC? Mifepristone, misoprostol, well, she's not asked you for an abortion, so I will not say that. Transvaginal sonography looks like a good answer. Laparoscopy, I know, I'm not suspecting an ectopic so far. Let me do an ultrasound and find out. So that is also a wrong answer. So yes, did all of you get it correct? Yes. Oh, initially there were some A's, a lot of D's, and now they are all D's. Okay, fine. So that is what we are going to do. With the values more than 1500, I'm going to do a TVS and look at the location. If the location is in the uterus, continue the pregnancy. If the location in the uterus and she's bleeding and she's having threatened abortion, give her progesterones. If the location is in the uterus and she's partly evacuated the baby, incomplete abortion, I'll do a curettage DNC. If the location is in the fallopian tube, I'll do a management of a ectopic pregnancy. Ruptured or unruptured, we'll decide. Okay, so that's the answer. Question number 7. Let's move on. A 30-year-old lady presents to the clinic for preconceptional counseling. She has a history of 4 spontaneous consecutive pregnancy losses between 5 to 10 weeks. Nowadays, we say recurrent pregnancy loss. Recurrent abortion is an outdated term. So we say any time a woman loses 3 pregnancies, whether it's in the first trimester, second trimester, or even third trimester, 3 pregnancy losses, recurrent pregnancy loss. All right. Recurrent abortions is a term which we keep speaking, in this discussion also. Today also I might say recurrent abortion because it's there in our genome, as an obstetrician we've been using this term. But now we say recurrent pregnancy loss, 3 or more. Okay. Now, she's had losses between 6 to 10 weeks. She says she takes her prenatal folic acid regularly, exercises regularly, consumes a healthy diet. On examination, her vitals are stable. Body mass index is 22, and CVS abdominal and pelvic examinations are unremarkable. Ultrasound, thyroid, sugar profiles are normal. A hysterosalpingography shows no uterine abnormality. Which the following is the most appropriate investigation? Right, guys. So, what are you answering? Torch profile, some of you said. Test for C, nobody is saying yes. Pooja has said now C. A lot of you have said C. Cervical incompetence. And anyone saying C or B? Husband semen analysis. No. See, husband semen has a role of, giving some infections or causing abnormal genes in a baby. DNA can be bad in a sperm after the man's age being 40. But once there's a pregnancy, sperms are generally not taken into investigation anymore, because most of the times that won't be a problem. I'm saying most of the times. I'm not saying it's a guarantee that the sperm will be fine. Now, semen analysis definitely not the answer I'm looking at. Okay, it is definitely not the answer. So, let us now see what can be the better answer here than torch. Torch is a cause of abortions, but torch is not trimester specific. Torch can cause abortion in the first trimester, it can cause abortion in the second trimester, but it is a patient who is having pregnancy losses 6 to 10 weeks. And torch does not cause recurrent abortions. Torch does not cause recurrent abortion. Now, that's what you have to understand. Okay. So, please, this is not the best answer here. So, test for semen analysis is wrong, torch is wrong. Test for cervical incompetence. Now, that is an anatomical cause of an abortion. Cervical incompetence is an anatomical cause, and cervical incompetence presents with abortion in the second trimester, 20 to 24 weeks. Painless cervical dilatation. Painless cervical dilatation is what is the presentation around 20-24 weeks, and painless abortion. So, that also is not the best answer here. Postcoital test is a test for finding if the sperms and the cervical mucus are having a good interaction when a patient has infertility. All right. So, yes, we are going to do a parental karyotype here. All right. We are going to do a parental karyotyping here. That's the best answer here. Nobody got it correct. This is for FMG too. Why not, Kavya Reddy? This is for FMG also. This is for NEET. And in this exam, maybe you not get such wordy questions. Maybe you will get around 50 wordy questions. But next exam is going to be the same for FMG and for for NEET exam, and MCI will be all next. So, next exam is going to be all clinical questions, 3 major specialties, and totally 6 subjects which are going to be clinically oriented subjects. Of course, your basics you cannot afford to forget, but all the basic subjects will be amalgamated into clinical science and given you as a situation. So, situation based questions is what is going to happen. So, Kavya, if you are not ready for this, get ready very fast, because if you pass your MCA exam this time, the exam for PG entrance is going to be this way. Another 3 months you will be reading these kind of questions only. So, yes, this is for NEET, this is for INI-CET, and this is definitely for MCI. Okay, it's the same. I've been saying this for the last 4 years. Wherever I've been taking classes, ever since 4-5 years PrepLadder has happened, I've been telling this in my live classes everywhere, that yes, I'm going to take only clinical questions. These recall based questions are not going to be coming, and this is what is finally coming to being by the Indian government also. All right. So, please don't look for easy questions. Look for clinical situations which you can solve. Can cervical incompetence cause repeated abortions? Yes, why not, Dr. Nisi? If you don't correct it, it can cause. So, quick, we can say first trimester first trimester, it is chromosomal causes, which is the main cause of abortion. Second trimester, the main cause of abortions are anatomical, which can be septate, bicornuate, unicornuate, or a short cervix like we are discussing here. Chromosomal, the most common are trisomies. Which is the most common trisomy? 16. So 16, 18, 21, etc. But common to these trimesters, I mean, it can cause, can cause abortions in any of these trimesters, like the TORCH group of infections and the systemic lupus erythematosus, antiphospholipid antibody syndromes, and the hypothyroidism and the diabetes, all right, syphilis. So these can cause many other causes, but these are not trimester specific. They can cause abortions at any of these trimesters, first and second. So these are the cause of abortion. Now, recurrent pregnancy loss or recurrent abortions, like you asked me, recurrent pregnancy loss, the most common cause are the chromosomal causes. Recurrent pregnancy loss are chromosomal. Please don't say antiphospholipid, don't say TORCH. Please, recurrent abortions are because of chromosomal causes. Now, if the patient has a cervical incompetence, he's got a bad septate or a long, a bicornuate uterus which is causing abortions, and you don't correct it, next time she's going to abort again. So yes, recurrent pregnancy loss can also be because of anatomical causes. Now, if you don't correct the sugars, you don't correct the thyroid, then she aborts this time, she aborts the next time again. So all of these, yes, all of these can go on to cause a recurrent pregnancy loss. But yes, only thing which you have to remember, the TORCH group of infections, that does not cause recurrent abortions, all right. So yes, what I've tried to tell you here, that chromosomal are the most common, anatomical and the other cause which I mentioned, they can also cause abortions. But TORCH group of infections, they cause abortions once, like rubella cause abortion this pregnancy, next pregnancy she is immune to rubella. So that's what is the MCQ which came. And yes, all of you, antiphospholipid antibody is not the commonest. No, I'm sorry, that is not the commonest cause of recurrent abortion. No, 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 it is chromosomal. All right, so let's move on and see question number 9. A 35-year-old lady, grade 4, para 3, life 3, presents to the physician with missed periods 1 week back, and she has positive home pregnancy test. Now she's 4th time pregnant, and she's got a positive pregnancy test. She, however, does not wish to continue pregnancy as she already has 3 children and does not desire more. Ultrasound suggests a single intrauterine gestation sac corresponding to 5 weeks. Which the following may be prescribed for this patient for termination? Question number 9. That's the somehow I've seen this part of the abortion class. Most of you are going to give me the right answer. Let's see. Because you doctors keep prescribing your friends who are non-medicals and your cousins who are asking you about abortion advice and your family members, and that is not a very good practice, because abortions can cause problems. Abortions can bleed, and abortions can even cause a patient to get very sick and require an admission. So please, as whatever amount of training you've had, you can, if you're an intern, you can start doing some treatments, but please do not advise abortions and do not give abortion advice. That's a very important personal advice I'm giving to you as a senior medico and a teacher to you. Please do not give abortion advice on the phone. Do not give abortion advice if you're not a gynecologist. It's none of your business, right? Abortions can be done only by a gynecologist, an MD or a DNB or a DGO, or a doctor who is trained in gynae for 6 months, or a doctor who has done 25 MTPs under supervision. Only these people can do abortions. Why? Because abortion can cause a woman to get very sick. So I'm pulling your leg, guys, but do not get into trouble, because you're still interns and you're getting into your medical life, and you may lose your license if things go wrong. So be careful. Okay. So yes, in the first trimester up to 9 weeks, yes, we can do the medical abortion. So that is 95% success, and if you do till 7 weeks, that is 99% success. So yes, it is recommended that you do till 7 weeks. You can do up to 9 weeks also, and that is done by mifepristone to kill the fetus. Mifepristone is an antiprogestin, and misoprostol to expel the fetus. So mifepristone, misoprostol. Mifepristone, the dose is 200 to 600 milligrams orally. okay, that's an anti-progestin, kills the fetus, and misoprostol is 800 micrograms. It is given vaginally. That's a prostaglandin, and that is going to expel the fetus. All right, yes, like I said, you're going to tell me the dose also, don't you? So that's what you guys are falling in the trap, which I just now said, that all of you know this topic very well. Yes, please don't prescribe, and don't try to help your friends, because you may actually cause them to get into trouble. Most of the times you'll get away with it, but the ones which get sick, those are the ones, few of those are going to get sick, and if you're not a gynecologist, then you're going to be big legal soup also. Let's move on. Okay. Question number 10. A 35-year-old para 1 live 1 lady presents to the emergency department with complaints of pain abdomens in 6 hours. She's not pregnant. I said para 1 live 1. Okay, don't assume her to be pregnant. She is unable to recall much and is complaining of giddiness. She does not remember LMP. Okay, she's got complete pain abdomen 6. She is unable to recall much. Okay, let's see why is that. On examination, she looks pale. Pulse rate is 132, BP is 90. Okay, yeah, she's getting into shock, all right. Yeah, that's why probably she's having giddiness and low blood pressure. So she's disoriented, not able to recall much, does not remember LMP. Okay, fine. 35-year-old para 1 live 1 with complaints of pain abdomen, and she's not able to recall much about a LMP. And chest and CVS are unremarkable. Abdomen shows rebound tenderness, and vaginal examination shows minimal bleeding. And cervical motion tenderness is present. All right, she is pregnant after all, I think. Fullness in the pouch of Douglas and tenderness. Now, what is that fullness in the pouch of Douglas? Now, that is what something all of you should know, that if you see the anatomy of the woman, this is the vaginal opening, this is the bladder, this is the abdominal wall, this is the rectum, and that is the sacrum behind. And this is the peritoneum fold over the bladder, behind the bladder UV fold, behind the uterus pouch of Douglas, and there is collection of blood here. That blood collection causes fullness. This is the pouch of Douglas. So when you do a per vaginal examination like this, then you put your finger here. Yes, does it show? If I can put, yes, if you put your finger in the vagina and you go into the posterior fornix, you will see fullness in the pouch of Douglas. So that is what is telling you that there might be some collection in the pouch of Douglas. So this kind of a story is mostly going to be a diagnosis of a ectopic pregnancy, which is probably ruptured. So ruptured ectopic pregnancy, what are you going to do? So this, yes, if you're having a question like this, then you'll think in terms of ruptured ectopic pregnancy. What are you going to do? Hospitalize and give IV ceftriaxone and doxycycline. If you're thinking in terms of PID, you'll do this. So we've discussed that. Nasogastric tube insertion, no, she's not looking as if she's got some obstruction of the bowel. So maybe this is not the right answer. Paracentesis collection. That is if you're thinking in terms of peritonitis. So maybe, but she could be in shock because of that. But let's see. Injection methotrexate, if you think if it is an ectopic, laparoscopy or a laparotomy. Okay, now between choice A, C, and D. So A, we are not thinking in terms of, she's got a history of only 6 hours. So 6 hours she will not have a sudden onset acute peritonitis. It will be, peritonitis will develop over a few days, and it cannot happen in 6 hours onset and coming to you in shock. Peritonitis doesn't present so fast. 6 hours can cause some, it can cause the patient to get slowly sick, peritonitis, and then it will take days for it to develop. So yes, I will not say the answer C is correct, and I will not say that answer A is also correct, because 6 hours to diagnose PID also, for a presentation of PID, to start and present full-blown PID so that she's gone into shock. So yes, this is a case of ruptured ectopic pregnancy, like I told you already. I was just trying to rule out the causes. So once you know it's a ectopic pregnancy who is in shock, so medical management is obviously out. So laparoscopy or a laparotomy is the best answer. Now, patient is relatively stable, 90/50. So a ruptured ectopic pregnancy, best is that you do laparotomy if there is shock. Laparoscopy you should do in a stable patient. So the choice given in this question is laparotomy or a laparoscopy. That is correct answer. Better answer in this, since she's got a pulse rate of 132, she's having giddiness, she can't remember much. So if you're a smart laparoscopist, if you can operate fast, then you can go ahead and do a laparoscopy. But best would be to do a laparotomy. All right. Yes, I have operated a lot of women in shock with laparoscopy, but that's a different forum where I have to discuss that, not the right forum. So, stable patient, do a laparotomy, okay, or a laparoscopy, but unstable patient, always do a laparotomy. So, in this one, I would rather say answer E is correct. Laparotomy, better answer for you guys. Okay, chalo. Question number 11, a 34-year-old lady who is gravid with para 1 with previous normal vaginal delivery presents at 31 weeks plus 4 weeks of gestation and complains of pain abdomen. She is pregnant having pain abdomen. She is bleeding and she is having adequate fetal movements. On examination, she has intermittent uterine contraction with a good fetal heart. Tracing, vaginal examination reveals intact membranes with 2 centimeter dilatation. Which of the following class of drugs is likely to arrest this condition? Now, this is a patient who is having some amount of bleeding and some amount of contractions, and I am thinking in terms of abruption, but they are not saying a uterine tenderness. So, I want to see uterine tenderness, I want to see high blood pressure to say abruptio placentae, or an injury or a drug addict or a smoker. None of that information is there. So, patient having pain abdomen and mild vaginal bleeding, it could be preterm labor also. So, let's see what are the what you can do to arrest this condition. Potassium channel opener. Oh, I don't know what is that. I seriously don't know how this came as a choice. Anyway, beta blocker, beta agonist. Okay, let's see out of these two. Antimetabolites, I don't know what is that. Selective estrogen receptor modulator, not at all for here. So, antimetabolites, of course, we are not going to give them here, and selective estrogen receptor modulator are drugs like raloxifene and tamoxifen, clomiphene. They have no indication in pregnancy with pain abdomen. So, yes, this is looking like a case of preterm labor. Now, what do you give in preterm labor? Yes, E is wrong, E is wrong. B, beta blocker. How many of you got B? Look, so many of you got B. Who is getting C here? Nobody wrote C. This is a case of preterm labor, guys. What happened? Okay, yeah, you know it is a case of preterm labor, but you forgot that for a preterm labor, you get beta agonists, not beta blockers. Okay, yeah, that's where you got it wrong. So, those who said something to do with beta, something to do with beta, that's why a lot of B's came. Obviously, the answer is not SERMs or antimetabolites or potassium channel openers. Calcium channel blockers will give nifedipine. So, the drug of choice for tocolytic is always nifedipine. And my favorite drug, which is a neuroprotective, second best drug is magnesium sulfate, because that's a neuroprotective drug. But yes, we should also know the mechanism of action. So, all of us know that we give terbutaline, we give salbutamol or ritodrin or even isoxsuprine. What are these drugs? These are beta agonists. Beta agonist action is a smooth muscle relaxant, the uterine muscle relaxant, all right. Oh, so you got beta blocker because you did not know how to choose between blocker or agonist. Beta agonist, guys, doesn't matter. So, yes, I hope you got that right now. Question number 12, a primary gravid at 30 weeks of pregnancy attends antenatal clinic with complaints of bilateral pedal edema. On examination, blood pressure is high, 160 by 110, pulse rate is 88. Tests show that HP is 10.8, TLC is 64, 6,400, platelet count is 2,40,000, fairly stable. Bilirubin is normal, creatinine is normal, 24 urine protein is 400 milligrams per day. Now, that is the only thing which is out of normal range. Most appropriate pharmacotherapy for this patient shall have which of the following action? Another drug on pharmacology. See, you cannot forget your pharmacology and your microbiology and pathology. So, please, all of that is going to be integrated together in these next questions. So, what are you going to do? It's a case of hypertension at 30 weeks. So, yes, what kind of drug you want to give? A, loop diuretic. Guys, are you answering the same question? Are you having some other presentation which is going on? Furosemide, okay, all these are contraindicated diuretics. So, furosemide, that's a question which has come many times. Furosemide, ACE inhibitors and beta blockers. These are contraindicated drugs for hypertension pregnancy. So, this is out, and this is out. NSAIDs, yes, you can give for tocolitis, but not for hypertension. So the only thing, yes, alpha plus beta blocker. Why? I hope some of you got it right. Yes, a few of you got it right. This is what I mean. If I don't write lebitalol, then you will not mark that. If I had written lebitalol, that you know in your sleep. At 2 o'clock in the morning, I wake you up and ask you what is the drug of choice for hypertension pregnancy, and you're going to say lebitalol. That I know, but you should know that lebitalol is an alpha and a beta blocker together, right? So beta blockers are contraindicated, not alpha and beta blockers together. So the alpha action contradicts the beta blocking action, and it's a very good relaxation of the blood vessels. So please, I think all of you should get that correct. Most of you, 50% answer correct, but a lot of you got that wrong also. So yes, let's move on. Question number 13. Primary gravid at 31 weeks of gestation presents with a blood pressure of 160 by 110. Proteinuria of 450 milligrams per day and lower limb edema. Ultrasound reveals a single intrauterine growth retarded fetus with diastolic flow dysfunction in umbilical arteries. The fetal Doppler, like I told you in the beginning of today's class, I said always do fetal surveillance. Fetal surveillance is what makes you an obstetrician. Now in that surveillance, we are doing the Doppler, and the Doppler is showing there is compromise in the diastolic function. Which of the following pathological change is most likely responsible for these findings? The patient is having hypertension in pregnancy. At 31 weeks, hypertension in pregnancy is because of what? Underdeveloped chorionic villi. What are you answering? Let me see that first. Question number 13, choice CCDD. Lot of C's. Excessive production of human plasma lactogen. Absolutely wrong. Human plasma lactogen is implicated in gestational diabetes mellitus. That is the answer for GDM question. So that has not been asked of you guys. So that is wrong. So a lot of B's are there. Deficient trophoblastic invasion of spiral arteries of the placenta. Looks like a good answer. Underdeveloped chorionic villi. Okay. Not the best answer here. Non-disjunction of chromosome during fertilization. Oh God, that's not going to make a fetus properly. So that's absolutely not wrong. That's absolutely wrong, I mean to say. Fluid overload in the placenta and maternal vasculature. How many of you got E? Did anybody got E? Thank God nobody said E. No. Enzil Ganger, you're trying to pull my leg, right? Just because I said nobody answered E and you're answering E now. So look, guys, fluid overload is never the cause of hypertension in pregnancy. You and me, of course. I mean, like you and me, like people who are not pregnant. I mean to say, you and me getting hypertension is because of fluid overload, okay? And we take diuretics for the blood pressure to control. But when women are pregnant, it is not volume overload, it is a vasospasm in the plasmal vasculature. So to overcome that vasospasm, mother increase the blood pressure. Now that is what is given here very nicely. Deficient trophoblastic invasion of the spiral arteries of the placenta. Now what is happening here, that the spiral arteries which are giving blood supply, they should be invaded by the trophoblast, and these arteries should become nice and dilated for the perfusion of the placenta. So when the spiral arteries are nice and dilated, that will give good flow to the placenta, and good exchange happens between the fetal villi and the placenta. So fetal villi in the maternal blood. So good vascularity of a placenta means a good healthy baby. So what is very important in that vascularity? The spiral artery should become nice and big and dilated. Now for that to happen, there should be a good placentation. Now I'm trying to show you that picture. This is inspired by the picture from Williams Obstetrics, which has been modified for us. And if you look at this one here, you see the anchoring villi in the first picture, and you see the cytotrophoblast. See these cells here, which I'm showing you, dotted cells. These cells are slowly going into the spiral arteries here. These are the spiral arteries here. Now see, these arteries are having this brown lining. That brown lining is the muscle in the spiral arteries. Now see, by the end of the diagram here, these cytotroplastic cells, they have replaced the smooth muscle. And can you see the diameter? Can you see the diameter here? See, the diameter here is less. See, the diameter of the blood vessel is much more here. So as the muscle layer is replaced by the trophoblast, the blood vessels become dilated, and that's what is going to give good perfusion. Now if that is inadequate, look in this picture, there is persistence of the smooth muscle layer in the spiral artery. So there is vasospasm and the perfusion is less in the placenta. So to overcome the vasospasm, the autoregulation increase the contractility of the maternal heart and the blood pressure increases. So to overcome that, maternal blood pressure increases. So the word which you have to remember is poor placentation. All right, that's a cause of hypertension pregnancy. NEET students, this is becoming a hotshot MCQ for you. Please guys, remember this very, very well. What else happens? The vasospasm. There is imperfect angiogenesis. Please remember, blood vessels should be dilated in pregnancy in the placenta and in the spiral arteries. The blood flow should be excessive. Dilated blood vessels are required. Now, for the normal endothelial relaxation, the blood vessels should have the transforming growth factor and the vascular endothelial growth factor binding with receptors on the blood vessels here, the 5 receptors mentioned here. These receptors, when they bind with this transforming growth factor and the vascular endothelial growth factor, they cause vasodilation, endothelial relaxation. Now, what happens in preeclampsia? In preeclampsia, this soluble endoglin and the soluble FMS like tyrosine kinase 1, the soluble FMS like tyrosine kinase 1, they will inhibit the binding of transforming growth factor and vascular endothelial growth factor. Can you see this? We're trying to show you here. See these diagrams which I have made, these are inhibiting the binding of these growth factors to the blood vessels receptors. So when this binding with the receptors doesn't happen, then the angiogenesis doesn't take. The growth factors are required for the growth of the blood vessels, angiogenesis. If that binding is imperfect because of 2 new things which are coming in your exams, NEET students, remember that soluble endoglin and the soluble FMS like tyrosine kinase. These are already commercially available tests. That's why they've been asked of you people in the exams already twice. In the last 2 NEET exams, they've come. If these are present, they're going to cause the binding to be poor and the angiogenesis to be imperfect, and that is going to make vasospastic vessels. So I've told you 2 mechanisms. One is that there is pH etiology. It's a 2-step etiology. Remember all of that. But yes, basic is that there is vasospasm. So one is this mechanism which I told you. The other mechanism is poor placentation because of the inadequate trophoblastic invasion of the smooth muscles of the spiral arteries. So yes, you'll have to go ahead and remember all of this, guys. Can't help it. It is all required. Okay, question number 14. A gravida 3 para 2 live 2 with previous 2 vaginal deliveries presents at 41 weeks and has premature rupture of membranes, PROM. What do you mean by PROM? Rupture of membranes before the patient goes into labor. Per vaginal examination revealed the cervix is dilated 3 centimeters and 1 foot of the fetus can be felt through the vaginal examination. The estimated fetal weight, fetal, sorry for that spelling, guys, and fetal weight is about 2.7 kgs. The fetal heart rate is reactive. Which of the following is the most appropriate method to complete this delivery? So she's in early labor. She's delivered many times, 2 vaginal deliveries, and now she's at 41 weeks with PROM. So these women should deliver normally, right? Gravida 3 and 2 previous normal vaginal deliveries. Now the problem is that when I do a per vaginal examination, I feel a foot of a baby. So when I see a foot, that means it's a breech presentation. So that is a flexed breech. Now this is a extended breech, and this baby is a footling breech. So yes, a flexed limbs, flexed breech, extended knee joints, extended breech, and this a foot in the vagina, footling breech. So flexed is also known as a complete type of a breech, extended is known as a frank breech, and footling is known as a incomplete type of a breech. And please remember, the most common breech is extended. Please remember, the best for vaginal delivery is also the extended breech. So yes, this extended breech will deliver, flexed breech will deliver. But if you feel a foot in the vagina, 1 foot in the vagina, not if you feel both the feet here, like if you see this example here, both the feet, if the first picture, if this one you feel, that is a flex breech. Both the feet and the buttock together, if you're feeling, then that is a flex breech. That can deliver normally. But if you feel just one foot, it's a footling breech, a lot of complications. One leg may stay up, might be extended in the abdomen, one leg might be into the vagina, one leg might be, the thigh might be flexed and the leg is inside the abdomen, and one leg might be in the vagina like you're feeling now. So this is a footling breech. A lot of cord accidents can happen and injuries can happen. If you see footling breech, do a cesarean section. All right. So the question here is for a footling breech, vaginal delivery with SZ breech, vaginal delivery. So we cannot do a delivery for this patient. So this is what is a footling breech. For a footling breech, what are you going to do? You're going to do a cesarean section. So that part is taken care of. Perform an emergent cesarean section. That is the answer to this question. Now, how do you do normally? What is the method of doing breech vaginal delivery? See, the answer to question number 14 is D for Delhi. That is already over. Most of you got that correct. Okay. Now, some of you said that we can do a normal delivery. No, we can't. Footling, cesarean. Now, guys, any breech, suppose there's a frank breech and you're going to do a breech vaginal delivery. What is the method? Do you do a breech extraction? We don't do that. Breech extraction means moment you see the breech, you start pulling on the baby. No. We let the baby deliver till the umbilicus. No touch till umbilicus. And after that, we touch the baby. So that is what. After that, you assist in the delivery. So assisted breech vaginal delivery is the method of doing a breech vaginal delivery. But in this question, it was a footling. So we had to do a cesarean. What is the method of doing a breech vaginal delivery? A assisted breech vaginal delivery. There is no spontaneous and there is no breech extraction. Okay, so don't say that. Rarely we have to do breech extraction, but that is following a internal portalic version for a transverse line. That's one indication for a breech extraction, but we are not asking that here. Breech extraction and spontaneous breech is not done. Assisted breech vaginal delivery is done. Okay, question number 15. A multicarrier presents at term in active labor with good uterine contraction. On examination, the cervix is 5 centimeters dilated and fetal head is lying at 0 station. The occiput is placed posteriorly in the maternal pelvis. The most appropriate next step in management is multigravida. She is having a cephalic presentation. Only problem is the occiput is placed posteriorly in the maternal pelvis. Occipitoposterior is the most common malposition. What is the most common position? Most common position of vertex is left occipitotransverse and then left occipitoanterior. Most common malposition is right occipitoposterior, and 80% it rotates to occipitoanterior and delivers, and 15 to 16% it stays occipitoposterior and that will also deliver. So please remember, occipitoposterior will deliver. Either it will become anterior and deliver, or it stays occipitoposterior and it delivers as occipitoposterior. So if you see, can you give me this? So if you look at this demonstration here, if you see the outlet of the pelvis, and this is occipito-anterior. In occipito-anterior, you can see this triangular, you can see this triangular frontanel. This is a triangular frontanel, that means it's the occiput. So when you see this baby coming out, this is occipito-anterior, delivers by extension. Now, if it is occipito-posterior, a little bit towards the right occipito-posterior. Now, when right occipito-posterior is there, it will hit the pelvic floor. Where does rotation take place? Rotation takes place in the pelvis. Where does the rotation take place? It takes place at the level of the pelvic floor, the levator ani. So at the level of the pelvic floor, when this occipito-posterior hits a little bit towards the right, it will hit the pelvic floor and it will rotate and become occipito-anterior and deliver by extension like it normally should be. So that is what happening. That is what is happening to all occipito-posteriors, 80% of them. It will rotate anteriorly and it will deliver. Now sometimes an occipito-posterior, which is, I'm showing you the right one, right occipito-posterior, it will not rotate favorably anterior. It will rotate posteriorly. Now this becomes a direct occipito-posterior. Now if it is a direct occipito-posterior, still there are good contractions, still the diameter of engagement is suboccipitopragmatic, it is 9.5. So this will go on delivering as occipito-posterior only. Now it is occipito-posterior, how will it deliver? This will also deliver by extension. Okay, occipito-anterior delivered by extension, occipito-posterior also delivered by extension. But now you see the occiput is posterior. What is facing the symphysis pubis? Can you see? Can you see what is looking up? The baby is looking up, the occiput is posterior. So this is face to pubis. Where do you see face to pubis delivery? You see in a persistent occipito-posterior. So that's what I was showing you here. Excuse me, guys. Excuse me. So 80% rotates to occipito-anterior and delivers. This will also deliver. 15 to 16% stays occipito-posterior and delivers by face to pubis. So if this is going to be the case that almost all the occipito-posteriors are going to deliver, so then allow progress and watch for delivery. External cephalic version is done for a breech, to get a favorable breech, a favorable head into the lower segment. So we turn the baby. So that is not done here. Internal protallic version is done for a second of twin in transverse lie. Okay, NEET exam questions, very regular ones, but not the answer here. Cesarean section, not at all. NEET exam, more than NEET, the INI-CET exam, they're very fond of asking, and in the MCI exam, yes, the INI-CET and then the MCI, these two exams are very fond of asking you occipito-posterior. INI-CET, they'll always ask you what do you do in a case of an occipito-posterior, wait and watch. What will happen to occipito-posterior, mostly it will deliver, these kind of questions. They asked in the MCI exam, what kind of pelvis will favor a rotation of an occipito-posterior and which pelvis will not favor occipito-posterior rotation. That was an MCI question. Kavya, you were asking me whether MCI is going to be asking such tough situations. MCI is asking still worse questions than the INI-CET exam. So guys, don't take your exam to be very easy every time, okay? Now it's going to become tough, okay? So yes, not a cesarean section, no, that's wrong. Okay. So let me see, I'll tell you the pelvis types, a little information. Gynecoid is the most common type of pelvis. Second most common type of pelvis is the anthropoid, and the rarest type of pelvis is the flat pelvis or the platyploid. Platyploid has the face presentation. Okay, now most common type of pelvis is the gynecoid. Gynecoid has a nice round pelvic cavity. Okay, but now look at the anthropoid. The side walls are parallel and the straight side walls are present in anthropoid. Can you see the android? The front of the pelvis is having a narrowness. So the front walls of the pelvis are converging. So that's why the cavity of the anthropoid and android is not a very favorable cavity. So when, let me draw here and show you, if there is this arrowhead is the occiput. So obviously this is the sacral promontory. So this is posterior part of the pelvis, posterior part of the pelvis and posterior part of the pelvis here. So in these three, if there's a occipito-posterior, the arrowhead, if you see, is the occiput. I'm trying to show you here. And in the first one, can you see the gynecoid pelvis, rotation here and rotation here is possible. So this is the best for occipito-posterior. Rotation is best, is possible here in a case of gynecoid. But now you see in a case of an anthropoid, this rotation is not possible. So that's the MCQ which came in the MCI exam. No rotation possible. But I'm not saying no delivery is possible. I said in 15 to 16% of cases, no rotation is possible. The baby delivers as occipito-posterior itself. So there you see face to pubis, like I showed you in the demonstration just now. So yes, no rotation possible, but delivery by face to pubis can be done in a case of anthropoid pelvis with occipito-posterior. Now in android pelvis, partial rotation happens and the next rotation does not take place spontaneously. Half rotation happens in the roomy back part of the pelvis in android, but the remaining rotation has to be done manually. So if there is a android pelvis, you will see rotation to occipital transverse, which has to be completed by the obstetrician manually. So we do manual rotation plus extraction by forceps. Extraction, I am writing EXTR. Okay, MRFE, manual rotation, forceps extraction. But if this is neglected, if the transverse, if this is neglected, occipital transverse, that will get stuck in deep transverse arrest. If it is a neglected occipital transverse, then suppose the woman is in labor for 4-5 hours in the village, and now she's in second stage for another 2-3 hours, and the dye has given up, and the patient is brought to you in the labor room in your tertiary care setup, and you do a PVNC that is in occipital transverse, and the head is edematous, there's no liquor. So then we call it a deep transverse arrest. So if you are given the choice as deep transverse arrest, then go ahead and do a cesarean section. Of course, this manual rotation forceps extraction is done in occipital transverse if it is seen in a labor room when there are specialist obstetricians available. Then you can do a manual rotation and forceps extraction. If they ask you deep transverse arrest, that term says that it's a neglected occipital transverse. Go ahead and do a cesarean. So rotation is possible in occipital posterior in a case of gynecoid and not possible in anthropoid. At least that much we should remember. Okay, I'm sure you've got it. Question number 16. A 29-year-old gravid to para 1 patient at 30 weeks of gestation presents with complaints of vaginal spotting. 30 weeks, vaginal bleeding. She is admitted to labor room for evaluation. Ultrasound reveals a placenta covering the internal cervical opening. Fine, that's a placenta previa. She currently shows no active vaginal bleeding. Fetal heart rate is 130 per minute. What is the next best step in management of this patient? 30 weeks, placenta previa, bleeding. What do you do? Yes, very simple question. 30 weeks, bleeding placenta previa. Now, when a patient has bleeding placenta previa at 30 weeks, remember, when we talk about the term placenta previa after 37, after 37 weeks term, if there is a placenta previa bleeding, so do the resuscitation and do a cesarean section. Now, before 34 weeks, this is the question which has come. Before 34 weeks, if your placenta previa is bleeding, conservative management is known to stop the bleeding in 90% of patients. So that is what is the McAfee-Johnson regime, that conservative management will stop bleeding in 90% of patients. So yes, cesarean, not the best answer here. ARM and oxytocin for normal delivery, not at all. This is a case of placenta previa. Resuscitation and observation in a high risk ward, yes. High risk ward, not word. I'm sorry guys for the spelling here. So high risk ward, you will observe this patient and the bleeding stops in 90% of patients. Of course, do a resuscitation. Give steroids also because the pregnancy is 30 weeks. And your conservative management will stop the bleeding in 90% of patients. Amniocentesis to assess fetal lung maturity. I know the lung won't be mature at 30 weeks. I'll give steroid to accelerate the lung maturity. So maybe that might be a vague answer correctly, but the best answer is C here. So D is not the best answer. No, I'm not going to do an amniocentesis at 30 weeks. I know the lung won't be mature. I will give steroids to, if it is around 34 odd, around 33, 34, 35, then I may say amniocentesis is incorrect. But that also we don't do much. So we will obviously think in terms of conservative management and that will work. Question number 17. A pregnant lady delivered a baby with normal expulsion of intact placenta. After half an hour, she starts bleeding per vaginum again. On examination, she's hypotensive and boggy mass is palpated per abdomen. Ultrasound shows retained placental tissues. What is the likely diagnosis? Now, this is mentioned as half an hour. After half an hour, the patient is bleeding again and there is some retained placenta. So, when they've said that an intact placenta was removed and then there is still a retained placenta, then it goes in terms of a suction surate lobe. That itself is the answer. Accreta is a condition where you will not see the placenta coming out completely. In accreta, the placenta is stuck to the uterus and only bits of it come out. So then you can think of accreta. So that's not the answer here. Adenomyosis is not the reason here, and membranous placenta is obviously not the reason here. So that is a suction surate lobe. If you see the placenta, this has the cord attached like this. another leisure vessel going like this to a small placenta. So yes, you delivered the placenta, and this small bit of placenta, the suction-shooted lobe, the accessory lobe stays back. That can also cause bleeding. Mostly present, if it is a very small suction-shooted lobe, may actually present with not this kind of PPH, not this kind of presentation, may present to you with a secondary PPH. Okay. Question number 18. A Grada 2 para 1 live 0 RH negative mother presents at 24 weeks with a report of a positive indirect womb test. Her previous pregnancy was terminated at 30 weeks due to hydrops fetalis. Which of the following is the most appropriate next step in management? I would have loved to see this patient much before 24 weeks. Now, they are saying she presents to you at 24 weeks. Okay, she is pregnant right now and indirect womb test is positive. That means the mother is already making antibodies against the antigen, the positive antigen of the baby. That means she is making anti-D antibodies in her circulation. They are already going to the fetus, and the fetus may be having some hemolysis because of the anti-D. So, mother is making anti-D. She's got the ICT positive. If the ICT is positive, if the ICT is positive, that means the anti-D antibodies are already made by the mother. So, she is already making the anti-D antibodies. So, those anti-D antibodies are going to the fetus and may be causing hemolysis. So, what do I do first? I will see how many antibodies are there. I will check the titer of antibodies. Yes, these antibodies are going to cause hemolysis in the baby, but the baby is having a hematopoiesis going on. So, if there is hemolysis, baby will take care of that hemolysis by making more and more RBCs. So, some hemolysis might happen without causing much harm. So, see the titer of antibodies. If the titer is less than equal to 1:16, that is most labs say a safe titer. More than 1:16 is dangerous for the baby. More and more, doubling titer we say 1:16, 1:32, 1:64, 128, 256 like that, doubling titer. So, if the titer is very high, there are more antibodies and there is significant hemolysis in the baby, still don't throw an alarm. See if that hemolysis is affecting the baby by causing severe anemia. Hemolysis might be compensated by the fetal erythropoiesis. If it is significant hemolysis, then the signs and symptoms of anemia will show. So, yes, what will you do? The most appropriate management here. A lot of you saying A, some of you saying C. Now, the baby is 24 weeks inside the mother's uterus. MCA, Doppler, amniocentesis, exchange transfusion, chordocentesis. To see how much of hemolysis is happening, you can do a chordocentesis. You can do an exchange transfusion through the chordocentesis. But first, you have to know the severity of the disease. So, for knowing the severity of disease, A and B are the best answers. Those who are answering A and B, answer is correct. Now, between A and B, which is the better answer? That is what is going to get you the marks. So, amniocentesis and see how much of bilirubin is there. It will tell me how much of hemolysis in the baby is there. So, that used to be the Lilly's graph, and too much of hemolysis, zone A, B and C, zone 1, 2 and 3. The highest zone, zone 3 had 3 subzones, and the highest subzone of the zone 3 is the worst type of hemolysis. All that is now outdated. I'm not saying outdated, not done much, because nowadays what we do not do an amniocentesis. It is supposed to be invasive. But what we do instead, we do the assessment of the hemolysis in the baby by seeing the middle cerebral artery peak systolic velocity. So, if there is so much of hemolysis, the heart rate will increase, and that heart rate will increase and the flow to the brain will increase as a compensatory mechanism. The fetal brain will have much higher systolic velocity. So, peak systolic velocity of middle cerebral artery if more than 1.5 times of the median value. Okay. It is a computerized, the data of all these values. So, whatever is the median value for this gestation, if it is more than 1.5 times, multiples of median MOM units, then we say it is significant hemolysis. So, that is the best answer, the middle cerebral artery Doppler. All right. Okay, so quite a few of you got that correct. Amniocentesis is old-fashioned. NEET guys, please remember amniocentesis used to be done, but yes, please remember nowadays we consider that to be invasive. So we go ahead and do a MCA Doppler. Question number 19. A 30-year-old primary grader presents to the labor room at 34 weeks of gestation with acute pain in the abdomen and decreased fetal movements for 2 hours. There is mild bleeding per vaginum as well. Ultrasound shows placenta in the upper segment. Her blood pressure is 150/94. Pulse rate is 90 per minute and she is afebrile, and the uterus is tender and vaginal examination shows a 1 centimeter dilatation. Fetal heart rate shows no distress. Which of the following is the best step in the management of this patient? So see here, she's 34 weeks of gestation and she's got a blood pressure of 150/94, and she is got some amount of bleeding per vaginum. So bleeding, high blood pressure goes in favor of an abruptio placentae. So when there is abruption, we know it is associated most commonly with hypertension of pregnancy. Both of these, like one other question earlier, we saw there was pain abdomen but not hypertension. So we thought of preterm labor then. But now this is clearly a case of abruption. So what is the management? All right, we've already marked an answer for you. Bonus for all of you guys. चलो ये वाला आंसर हमने दे दिया आपको, so that you guys don't mark wrong. That's a mistake, guys. I shouldn't have marked the answer. So immediate lower segment cesarean section, so that's not the answer. Abruption by itself is not an indication for a cesarean section. Yes, abruption with fetal distress definitely is. Abruption with maternal compromise is, but if there is a normal fetal heart rate tracing like given in this question, no cesarean. So yes, I'll do induction of labor, that is with artificial rupture of membranes plus oxytocin. All right. So pardon the mistake of giving the answer already. That takes away the suspense, but I'm sure none of you should have said tocolysis. None of you should have said tocolysis. Yes, tocolysis is not to be given when a patient is in abruption. That will increase. So no conservation also. McAfee-Johnson is not done for this patient. It was done for placenta previa. So we don't do conservation for abruption. Abruption can cause DIC. Placenta previa, conservation is successful in 90% of patients. So conservation thought comes only around 34 weeks and before. After 34 weeks, any APH you think in terms of delivery. So before 34 weeks, you think of conservation. Now, which one you will conserve? Only placenta previa before 34 weeks. Abruption before 34, after 34. Both mean delivery. Only difference before 34 weeks is you will give steroids. Steroids, NARM. That's what we do. Okay, so answer is B for Bombay. Now, again, the answer is given. Okay, I shouldn't have seen these two questions. Beg your pardon, guys. 23-year-old primary gravidae presents in labor for delivery. She's a known case of rheumatic heart disease. After delivery of the placenta, the patient starts to bleed heavily. All of the following drugs may be used for the management except. Now, that's an easy question. What are the conditions where we do not give methyl ergometrin? So, answer is B for Bombay here. And remember, methyl ergometrin is contraindicated. We call it methergin, the trade name. My favorite drug actually. Look, all of us know that the drug of choice for prevention of PPH and for the treatment of PPH, the drug of choice is oxytocin. Khatam ho gayi baat. That's all. We know that very well. Oxytocin is that drug. But those of you going to become obstetricians, those who are going to do gynecology, boys and girls, remember, bank on methyl ergometrin more than oxytocin, okay? And then think in terms of carboprost as a good option, okay? Nowadays, a lot of carbetocin is given, but you know, people like me who've spent, last 26, 27 years of life in the labor rooms, please remember, we are going to have more importance of methyl ergometrin than oxytocin in your practical life. Yes, drug of choice is oxytocin. Go ahead, go keep marking that in your MCQ exams, but don't say in your private life always oxytocin. Methyl ergometrin works wonderfully. Okay, fine. That was a personal advice. Answer to the question of drug of choice is oxytocin. Now, why methergin is not given in some conditions? That's why it is contraindicated, because it causes a very good, wonderful contraction. Within 90 seconds, the uterus will contract and give a very good prevention and treatment of PPH. But the problem is when sudden contraction happens, the uterine volume 800 ml to 1000 ml will go into the circulation of the mother. So if she is a hypertensive patient, she'll have a hypertensive exacerbation, she may have an eclamptic fit, and if she is a case of heart disease, then that is going to cause the mother to have a load increase on the heart and she may go into failure. And if it's a case of Rh negative pregnancy, sudden contraction of the uterus is going to push more fetal blood into the maternal circulation, and before second twin. So these are the conditions where we do not give methyl ergometrin. So that's what one question was here. All right, guys. So what else are you asking me? Sir, barbiturate used for breastfeeding. Raj, I'm not able to get your the message you're trying to. Are barbiturates given for breastfeeding? You mean to say are barbiturates given when a woman is breastfeeding the child? Yes, we can give the excretion of barbiturates in the therapeutic dose for the mother. Let's say a woman is having a cesarean section and we're giving pain relief. That amount of pethidine, if you're giving, is not enough to cause sedation in the baby. All right, if that is the question given. So when a mother is breastfeeding the child, let's say after a cesarean section, and you're giving pain relief by pethidine or even morphine, so that amount of excretion is not there, which is going to cause the baby to get sedated. So that's all right, if that's the question you're asking me, guys. Okay, so please, I'm seeing your comments still, but I'm trying to say that please keep looking at the pro plan, and there are a lot of concessions given to you guys. And remember that we are having this discussion with you guys because all of us know that these questions, you know, by the medicine teachers and the surgery teachers, gynae teachers, all these discussions are being done so that you are next ready and all of you know the importance of the clinical situations which are coming in the exams. Needless to say, all of your basic primary knowledge of path, microbe and physiology and biochemistry is going to be put into use. But yes, please be ready for these next situations with the clinical questions. All right. So what did you ask me? All right. That's a great new name I saw, Dr. Vij fan. Thank you so much. That's very sweet of you. And Dr. Lulu, I'm there in Hyderabad at least 6-7 times in a year, and that'll be great. If you're a gentleman or if you're a gentle lady, let's have a coffee sometimes. Why not? And okay, if there are no more comments, and we had a long discussion since yesterday, and I hope all of you are taking this for your NEET exam as a good indication that clinical questions are going to be the way the questions are going to be asked. Those who are writing the MCI exam, another 15 days, I hope all of you go through this. And INI-CET and NEET students, please remember that the more you work in your internships, the more you see cases and more you discuss with the PGs. Yes, you're going to write a lot of discharge summaries and you're going to get a lot of investigations. But after you do all your job of writing the discharge summaries, make life hell for your postgraduates. Ask them a lot of questions. Tell them why you're sending these investigations, why this report is not good and why this report is good, and why you so hell-bent on doing this test at least every second day in this patient. So that kind of knowledge which you learn on the job, those points which you get on the job, those become your MCQs. I'm telling you guys, once you do that, then all these questions will become second nature. And what's the government doing now? They're going to make sure that you do internship very well so that you will pass to second part only after the internship. So guys, the value of doing a very good internship is going to be now realized. And of course, like I said in the beginning of the lecture, it's going to save somebody's life in your family. Thank you guys, and let's keep meeting on these forums. God bless you. Do well. Bye-bye.